Good evening, everyone from Nepal. And today, this is the webinar. We welcome to you today's webinar. This is the topic. Title of this webinar is Nepal's success in reducing maternal and newborn mortality, a focus on inequality and the learning health system approach. And this webinar is brought to you by the Nepal Public Health Foundation and the Global Health Network, University of Oxford. So this webinar will be both interactive and it will be like a didactic as well. And speakers will be there and the panelists will be assisting to help you all. And all attendees will have some comfortable environment with our speaker and our panelists as well. Now, I think the many attendees are coming to our session, and we'll be starting soon to our going soon to now. This webinar is especially focused on the Nepal's success in reducing the maternal newborn mortality, and we'll give some overview and our experiences from our distinguished Professor Sudha Sharma. And my name is Gehanath Baral, the Professor of Obstetrics and Gynecology at Kathmandu University. I am delighted to chair it and to be with our distinguished speaker, Professor Dr. Sudha Sharma, along with our Executive Chair of Nepal Public Health Foundation, Professor Dr. Mahesh Maske, and our Public Health Foundation teams are there to help you all. And Mr. Louis will be assisting in all housekeeping and all issues. Today's attendees are many, almost more than we received 220 registrations from 52 different countries and with different time zones. So some will have some discomfort on attending this, but this is the usual thing that it occurs everywhere, and we are managing our time as well. And if any questions you have already put during registration will be addressed accordingly. And if you have many questions or similar questions, we will be addressing singly. Or if there are so much of questions that we cannot address in this session, it will be compiled and addressed by write-up later on. Now, I like to introduce our today's distinguished speaker, Professor Dr. Sudha Sharma, and she is the obstetrician and gynecologist, and she is the most dynamic and most efficient administrator, public health expert, and specialist in maternal and child health. She holds degree of specialty in obstetrics and gynecology as well as public health. And she served as a Secretary of Ministry of Health and Population in the past. She was the director of the Paropakar Maternity Open Hospital, that is the central referral hospital of the Nepal, and that addresses many maternal child issues in the country, and everything is done from there, and the experience will be shared from the huge magnitude of obstetrics and gynecological programs, and there she led that hospital in the past as a director. And she at present she is the co-director in Ciwec Hospital in Kathmandu, and she is the chair of the International Representative Committee of the RCOG as well. And she is her degree is FRCOG after her specialty in obstetric gynecology, and did MPH as well. Now, with this short intro, I request Dr. Sudha Sharma to come with your agenda and your presentation. Dr. Sudha, the screen is yours.
Thank you so much, Dr. Baral. Thank you for your kind introductions. And thank you, everyone, for coming. Namaste and good morning, good afternoon. I'm at the morning time zone. Good evening to you all. It's my great pleasure to talk about some of the issues in Nepal, which you have seen from the intro. Now I will just share my slides with you, and then we'll talk further in a minute. So the title of my presentation, as you can see, is in Nepal's success in reducing maternal and newborn mortality. And the study actually focuses on inequality and the learning health system approach. This study was jointly done by a team from Nepal and from London School of Hygiene and Tropical Medicine, Professor Una Campbell and her team, Dr. Other colleagues. Were also part of the team. So why the study? You know, between 2000 and 2020, maternal mortality ratio dropped by 34% worldwide. And South Asia had an impressive decline in MMR of 67%, but still it accounted for 16% of maternal deaths. So that is about 47,000, which is a huge number. If you look at Nepal, the maternal mortality ratio declined by 6.2% between 2000 to 2017, a very impressive decline. And newborn mortality reduced by 3.9%. So both of the maternal and newborn mortality decline were above the average for South Asia. For maternal mortality, it was 5.3 for South Asia, whereas Nepal had it at 6.2% decline. Newborn mortality average for South Asia was 3.3, but Nepal had a 3.9% decline. So, and there are other countries in Asia which had made a decline as well. So for this Global Health Exemplar Studies, which was funded by the Bill and Melinda Gates Foundation, and as I said before, for the Nepal study, London School of Hygiene and Tropical Medicine was the partner. Then there were other colleges and partners for other countries as well. So South Asia, in South Asia, we were 3 countries selected: Bangladesh, Nepal, and India. And in North Africa and Middle East, Morocco was selected. And from Eastern Africa, it was Ethiopia. From West Africa, it was Niger and Senegal. And based on the newborn mortality and MMR decline, also it was adjusted for GNI because, you know, in developing countries, there's less resource. But despite the less economic resources and other resources, how could the countries achieve success? That was an area they wanted to explore, and also data availability, because it's a mixed method study. We didn't do any data generation. We did a qualitative aspect of data generation, but quantitatively, we used what was available in countries. And we took each of the region of the world, as I said to you, and feasibility was another consideration. So it was a mixed method study between 2000 to 2020. So we haven't gone far beyond 2000 looking at the trends. So we focused between 2000. Although in my study, I've just outlined a few other things that we did even before 2000. So I think many of you know where Nepal is. It's situated between China and India, India on the south, China on the north, and also on the east and west parts of India. It's a federal democratic republic at the moment, but we've had many political upheavals. It was a kingdom, later became a democracy under the king, which constitutional monarchy. And finally, constitutional monarchy was also done away, and we went into a federal system since 2006. And we had an interim constitution for quite a number of years. And later, from 2015, we have the constitution of the Federal Democratic Republic of Nepal, which also led to some of the significant reforms in our health sector, which I will show you in a minute. It's geographically, the area is quite small and very, very diverse. but the population size is 29.2 million, according to the census done in 2021. The male is to female ratio is 48, 52 approximately, 51.7 something for women. And as you may know, Gautam Buddha, the person who's under whose name the whole Buddhism is propagated throughout the world, he was born in Nepal, in Lumini. And if you have not visited his birthplace, you must do so. And Nepal is a very diverse country in terms of its religious and cultural diversity, languages and people, and the geography, because it has 8 of the tallest mountains in the world, and also the mid hills and the plains of Terai, so great diversity in a small geographical area, diversity in nature, in culture, in people, in languages, in everything we do. And that sounds so good, but in terms of providing services, that poses a great challenge. Some of you have asked in your registration question, what are the challenges? So these natural things also tend to be a challenge to some extent, but it's wonderful and it's beautiful. So if you have not visited Nepal, do please visit. Now with this, I go to the actual presentation of Nepal's major policies, programs, and laws. As I said before, although the study focuses the period between 2000 to 2020, I discussed about earlier about the kingdom and then constitutional monarchy. And even before that, I didn't go to what was before. Before we had the kind of autocracy, and we were really in kind of dark ages. At that time, we have like organized health programs started only in 1959 with a family planning project, which used to be called MCH program, Maternal Child Health Project in 1968. And I talk about learning health system of Nepal because while other countries were already well advanced, we were just starting to crawl and walk. But then we have run with great speed like a marathon runner and have achieved our success. So the International Conference on Population and Development in 1994 and the first ever Safe Motherhood Conference that happened in 1987, if you know, that took place in Cairo. And the landmark article by Alan Rosenfield and Deborah Main, which said, where is the M in MCH? Because globally, they were just focusing on antenatal care. They did not, and they, as you may know, they would screen women into high risk and low risk. But as we as obstetrician and clinical service providers know, there's nothing like no risk. Even the low risk converts into a high risk during labor, during delivery, because PPH can happen to anyone, even a multipara who is supposed to be a low risk. So there's nothing like no risk. So the maternal health needed specific focus, which was actually brought forth in around 1998 through the Nepal Safe Motherhood Program in 1997. And Nepal developed its national reproductive health strategy, and then abortion was legalized around 2002. And then we also had adolescent sexual reproductive programs. Then around 2006, the safe motherhood policies, especially skilled birth attendant policy, was brought about, which I have not shown here in the slide because, putting everything together was difficult. But at the same time, on top of what I have shown here, there are many other policy documents which took us to the path of this marathon running, And then most of the important thing that I want to highlight is the Safe Delivery Incentive Program, which was brought about in 2005. Our hospital attendance for deliveries was very low at that time. So government gave certain incentive to women to attend the hospitals. And later, the AMA program was brought about in 2009, which completely eliminated the user fee and then free newborn care package. And after the federal democratic constitution came about, it had health as human rights in the constitution itself and reproductive rights in the constitution itself. So we had the Safe Motherhood and Reproductive Health Act. Because of the constitutional mandate, we developed the Safe Motherhood and Reproductive Health Act later on, which you can see on the slide. Yeah. And the key elements of Nepal's health sector strategy actually focused on equitable access, quality health services, health system reforms, and multi-sectoral approach. In the center was universal health coverage. We wanted to reach everywhere to anyone because that was the constitutional mandate. And also the focus was an equity because I've told you, like we have these geographic diversities, then we have diversity because of, rich and poor and different ethnic groups, and then their behavioral practices. So a blanket approach to service would not be sufficient in our case. So an equitable access approach was chosen. Quality continues to be the issue in most countries, and even so in our case. So all of these kind of blocks were concurrently looked at. And as things were happening in the health sector, which I will show you the details later, the country, from this traditional political upheavals to modernization and, making life easier for people, was increasing the road length. As you can see, road length in kilometers in the red graph, and also the total number of vehicles that have been registered. As you can see, there's a steady incline going up, and then the bus stops and passable roads, they are increasing in number because during winter months and during rainy season in the Himalayas, during winter months, traveling is impossible because of the snow. And in the Terai plains, traveling becomes almost impossible due to the floods and the rains and so forth. So vehicle passable roads, as you can see, have been gradually increasing. And then if you look at the ownership of motorized vehicles at the household and cluster level, all the red dots are 0. Then the dark blue ones are 20 to 50. So things have gradually gone from 0 to 50, but in the mountainside, you can't have motorized vehicle that many, but in the plains, you see a lot of improvement. And then ownership of mobile phone now is over 90% in most parts of the country. That way, overall economic development and development in physical infrastructure has taken place. Basic sanitation used to be a challenge. Now, basic sanitation is almost universal. And then access to electricity used to be a problem. In my lifetime, I have operated on the torchlight, but now most of the theaters in the country do have electric lines and, clean running water for hand washing. So those were the basic things which were not available, but things have been improving gradually. And expenditure in public health has also improved gradually. Although in terms of percentage, we are still low at around 5%, but in terms of the volume of the government's budget, that has increased. So although the percentage does not seem to have actually increased, but health volume of the money that goes to the health sector has increased significantly compared to what it was in the past. And also the expenditure. Although we did get money, we did not have a spending capacity. But as you can see, health expenditure has also increased gradually, and we are doing fairly well nowadays. So that was about other infrastructure done by other departments of the government, not necessarily Ministry of Health and Population. Now I'm coming to the ratio of doctors and nurses per 10,000 population. Currently, the nurse midwives per 10,000 population is at 33%, and the doctor per 1,000 population is around 5%. So, but in terms of production, the number of production of doctors, now it has significantly increased. Just 2 decades ago, the Nepal Society of Obstetrician and Gynecologists, we had less than 200 members. Now we have over 1,000 members. So things have really, really improved. And we have, when I was a student, we didn't have a medical school in Nepal. I studied from India and did my post-graduation from the UK. And so did many of my colleagues who are in this talk right now. But now we have nearly 20 medical schools and various universities producing thousands of nurses and doctors, and things have really improved a lot. But in terms of retaining them in the country, in terms of distributing them to, inequitable parts like remote parts, is still a challenge, because it's not just the healthcare provider. We have to have the entire team of health workers. A solitary person cannot do much. And also other infrastructure, like schools for children and other things, are not as developed. So despite the increase in the total number of health workers, distributing them equitably and retaining them in their workplaces continues to be a challenge. And in terms of human resource, how we have progressed over the years. Initially in Nepal, in the 1950s, there were just the traditional birth attendants. There was nothing apart from that. Then we evolved to training of the traditional birth attendants, just giving them some practice of hygiene. Then we said, no, that's not enough. Then we started with training of maternal child health workers, just a 3-month basic training, how to cut cords cleanly and how not to put, those damaging things on the cord, and how to keep the baby warm. Those were the basic kind of skills. And then immunization of newborn and breastfeeding support. So those were the kind of health workers we had. Then we had, then gradually we moved to the auxiliary nurse midwives, which is 18 months training. These are the formal trained nurses. Then we said, no, that's not enough. We have to further give them the skilled birth attendant training. That was the policy I discussed, I told you about earlier. In 2006, we had the SBA, skilled birth attendant policy, which took actually 3-pronged approach. One was to give skilled birth attendant training to already existing nurses, staff nurses trained for 3 years, and auxiliary nurse midwives trained for 18 months. So additional SBA training to these people. That was the first approach. The second approach is modify their pre-service curriculum to incorporate SBA skills in the pre-service training itself. That was the second approach, which was the intermediate approach. And the long-term approach was to actually produce midwives, 3 years full midwifery course. And then some of them go after staff nurse training to midwifery. And they do post-basic training in midwifery also, like bachelor's and master's. So these are the steps we've taken gradually. And even now, currently, the auxiliary nurse midwives, they're posted in health posts at the most peripheral level. Now, these health posts are called basic health facilities, basic health units. And staff nurses are posted in primary healthcare centers and hospitals. And most of these places have the BMOC, basic emergency obstetric care facilities in PHCs, and hospitals have the CMOC, Comprehensive Emergency Obstetric Care Facilities. And the in-service training and other things I have highlighted here. And other health resource for maternal health work consists of training of doctors, the MBBS doctors, just graduate doctors, on advanced SBA skilled attendant skills, including cesarean section, anesthesia. Then we have a program called MD General Practice, which is a 3-year program, which teaches the doctors after the MBBS into being a postgraduate specialist as a GP, and obstetrics is a core part of the curriculum as well. And then we have a diploma, a 1-year course for OB-GYN, for pediatrics, for anesthesia. And then we had the 3-year MD course gradually started, so postgraduate anesthesia, pediatrics, gynae. And then we have programs of other countries also run in our country, which includes the membership of the Royal College of Obstetrician Gynecology, fellowship of the college in terms of preparing surgeons, FCPS from Bangladesh and Pakistan. So all of these programs also run in the country. So as a result, our human resource production has really, really improved now. And like I said before, but the fair distribution continues to be a challenge. And because of the road infrastructure I had shown earlier, now government has also put up health facilities where it's accessible. And the nearest health facility within 30 minutes is now almost 100%. The last grade bar is the 2011 figure, which was around 86%, whereas in 1996, less than half the population could reach health facility within 30 minutes, but now almost everybody can reach health facility within 30 minutes. So we talk about inequities, right? How do you reduce the inequities? And I have tried to here show the difference in access in institutional delivery across geographic regions. So if you look at the light blue color, this one here, that's average for Nepal. The trend is increasing. In 2009, only about 9% women delivered in health facilities, whereas by 2016, 57% of women had delivered. This is the old data. And when we did the study in 2020, the new DHS had not come. But the new demographic health survey and also the government's health reports show that it's now almost 90% home institutional births. So from 9% to 90%, it's, you can imagine the progress. It's so significant. But in the mountains, and because of the distances and because of the difficulty in access, the progress has been rather slow. In the Tarai region, progress has been very fast, but utilization, because of the cultural barriers, because of other barriers, tends to be, although availability is there, utilization tends to be a problem. So in terms of the diverse ethnic groups I had mentioned, if you look at the Brahman Kshatri group, which they believe is the most privileged group, but not privileged in the sense of economic privilege, and also geography and education affect these people as well. We should look at the term Dalit, which used to be the most marginalized. And this is Demographic Health Survey 2006, which shows coverage was only about 10% for Dalits. But now, by 2016, coverage for Dalits was nearly 50%. And now it's in the range of 70%. So although a gap still exists between the most privileged here, this is the Newar population, mostly in Kathmandu, around 80% in 2016, to the Dalits, which is around 50%, the gap still exists. But in terms of progress within that group, they have really progressed. So from Newar, if it has reached from 50 to 70, 20% increased, but here from 10 to nearly 50%, 45%, a significant increase if you look at that way. So things are closely monitored by various studies, and we try to ensure equitable distribution, but like I said before, challenges do persist. And that was the caste. I showed you the geographical distribution, caste distribution, and now I'm showing you the change as per wealth quintile. So this is the 4 times antenatal care visit. Here it used to be the lowest, and that was the highest. Now see, the lowest has come up to almost close to the second one, and then the gap has significantly reduced. The same thing here for institutional delivery. In 2001, it was almost none for the lowest wealth quintile, but the lowest wealth quintile now is around 40%. And if you look at the postnatal care, this is the weakest point in our maternal care system, because antenatal care and institutional delivery has received a lot of attention. But postnatal care, we don't have a system of home visits by trained health worker, and also the cultural taboos associated with, post-delivery ritual purification and so forth makes it difficult. But if you look at the improvement, it's still there, but in some of the groups, it's even less, because they don't go to the health sector for postnatal visits. So it is the okay. This slide is about the content qualified antenatal care score. So we improved antenatal visits, but did we give all that we need to give? For example, measuring blood pressure, to checking urine, to weighing the woman, and doing the necessary tests. Did we do it all? That is looked at by the content qualified antenatal care. So see, if in 2001, the content for this poorest group was almost 1, yeah, but by now it's come at 7. So we have not just improved the number of visits, but we have also improved the content of the care that's provided in each visit. And today's topic, as you can see, the title is about inequality and the learning health system. So far, I've shared with you how we focus on reducing inequality and barriers to care. But now I'm giving you an example just from one program. We have several examples from other programs, which I will not go into the details here, but just one program I would like to share. In 2005, Nepal introduced the Maternal Incentive Scheme program, which I mentioned to you earlier, because studies showed that only 9% of Nepali women attended health facility for delivery. Cost was identified to be one of the 5 barriers to care seeking. So we said, okay, now we have to remove this barrier. Government gave them transport incentives. 500 rupees for the Tarai region, where transport was easily available. Then mid hills, 1,000, and 1,500 for the mountains. So that was just an incentive and help to the women, so they could not be home because they didn't have transport cost. So that was done. And later, we looked at the human development indices of our multiple districts and saw that some of the districts with the really poor HDI, now, although we gave money to come, it wasn't enough. So there we had to start free delivery. So in 25 districts, free delivery services were started. By 2009, we said, okay, those districts are doing okay now, but I mean, they were progressing, but they were not really okay. Then we said, no, Nepal as a whole, if we have to achieve the Millennium Development Goals, we have to do much better. And I am very, very happy to share with you that Dr. Maskey, who is joined in this program, he's right here with us in the talk. He used to be the advisor to Honorable Minister of Health, and I used to be the secretary in the Ministry of Health. So together, we started the Amma Suraksha program, which is free delivery care across the country for everyone, including the transport cost. So women not only got the transport cost, but they also got free delivery care. Whenever they go to a health facility, they don't have to pay a penny. So that was what we did. And to most my satisfaction, I've left the Ministry of Health 15 years ago, but the program is running even now. And like I said before, almost 90% women across the country are having giving birth in institutions. So what a tremendous progress. And I think this is a very rewarding part of the work that I personally did. And I'm sure Dr. Maskey feels the same about his contribution to this task. And although institutional delivery is improved, like I said, but our antenatal care for was less. So government gave antenatal care incentive also to women. If you attend 4 antenatal visits and if you deliver in hospitals, you will be rewarded at the end with certain cash incentives. And the best part of this was, women empowerment was brought about by giving the cash incentive for transport as well as for 4ANC was to the women in their hands at the time of discharge from health facility, not to the guardians, not to the husbands. So women received the money and they felt so good about it, you know. So that is how it was done. And those were the steps taken for maternal health. But for newborn, the leadership, which was in the ministry in 2016, felt that we have to also improve newborn care. So even for newborn, demand side financing was added for free newborn care. But it was seen that we could really not sustain the free care for newborn because of the cost implication of various levels in various level hospitals, and ensuring that the money was actually being used properly was a challenge. So we studied, and then the study findings showed that, well, now I think we need to reassess the utility of this program. So free sick newborn care program is removed. Not removed, the care program is not removed as such, care program is going on, but the universality of the free care for newborn, that somehow we could not ensure that the money was being spent well. So what I'm trying to say here is, for every little thing, we have studied, we have looked at evidence, and then we have scaled up and scaled up. And then when we see that things are not working, we have even tried to modify or switch altogether to different modalities. So that is what is looked at by evidence-based practice, as well as the learning approach that Nepal has taken. And I'm very, like I said before, I'm very proud of the fact. And in the start of my presentation, I had told you that we were crawling while other countries were already well advanced, and we tried to run a marathon. Now you see, I just show a few slides to compare. This was Bangladesh, 8% institutional delivery. And in 2019, they were at 53%. India, they started with 34 in 2000. By 2019, they were at 79. Nepal at 2000 was at 90%, but then by 2019, we had reached 78%. See the progress? From less than 10% to 78%. And then this is Senegal, Ethiopia, Niger. So I'm just comparing with 3 Asian countries. And the common element in all of this is expanding health infrastructure with demand generation by empowering communities. And then in terms of antenatal visits, Bangladesh was at 11% in 2000 and 37% by 2019. That was the latest survey data. India was at 30 and 51%. Nepal was at 14 and reached 78% with ANC4 by 2019. See the learning approach that we have taken, looked at what works, what doesn't work, and try to give more. So really significant improvements in these areas. So we remove financial obstacle, and then in multiple countries, the private sector has come up in a big way, even in Nepal. But in Nepal, the government sector continues to function much better. And if you look at the access to cesarean section for poorer women, in Nepal, it was 0.3%. 3 in 1,000 women received care. Now it is 5.2%. In India, it's at 5%. In Bangladesh, it is at 13%. And this is because of the innovative approaches we took for human resource, including training, advanced training to medical officers to perform C-section. And then if you look at the system reforms to enhance management and decision-making, monitoring and supervision, then this is the antenatal care. It was blood sample taken. So see, every country, 60% Bangladesh, 73% India, 80% Nepal. So, and then blood sample not only taken, but referrals, improvement for postpartum care, postpartum hemorrhage, etc. That's also happening. But Nepal, as you can see, is a mountainous country, and so very, very difficult. But despite that, we have made progress. And let's look at the place of birth. This dark one is hospital, and this is lower level facility. And the very light one is home. Yeah. And this is arranged according to the transitions in labor and delivery. Nepal is at third. I didn't see the transition slide, so you might find it a bit difficult to understand. But Nepal, 2024. Okay, just let me go to this slide here. This is driven by hospitals. 63% of births is happening in hospitals in Nepal. And 16% is happening at the lower level health facilities, and around 20%, that was the data in 2019, around 20% was happening at the home level. But the majority was in the hospital, but mostly in government sector. Whereas in India, 62% was happening at the hospital level, 27% at the peripheral facilities, and 11% at home. That was 2018. And Bangladesh data is here. 24% at hospitals, 30% at peripheral level, and 47% at home. But this 24% is mostly private sector hospitals. And what is unique there is C-section rates are increased. So I try to assess what is the common factor in these three countries. I'm comparing only Asia here because the context is similar. Early marriage is common in all three countries. Teenage pregnancy, almost similar data in all countries. In Nepal, it's 14%, but range is 8% in Bagmati province, which is the center, to 21% in Karnali province, which is the remote western part of Nepal. Anemia, prevalent everywhere. 42% ever married women, and 52% of women who are pregnant in India, 34% of women 15 to 49, anemic overall in Nepal. So, anemia is common. Underweight is again common. Obesity is slightly increasing in all of these countries. So, early marriage, teenage pregnancy, anemia, underweight, and even obesity now, rising as a cause for underweight, as a cause for maternal risk factor in these countries. So much of similarity, but so much of progress in each of our countries. So, common drivers for change. Those were the challenges, but what are the drivers for change? Despite early marriage and everything, fertility reduction has been significant. So, less number of babies, less number of deaths. Shifting family norms, contraception, access to abortion services, migration, especially in the context of Nepal, later age at marriage. Although teenage pregnancy is still predominant, but by and large, marriage age has shifted to later age. Household living conditions have improved. Education is on the rise. Empowerment and nutrition is getting better. Government commitment is strong. Progressive implementation across these countries. Health policy and system changes, including roadmaps, laws, and regulations. Increased investment in health infrastructure, domestic production, and low cost of drugs, especially in Bangladesh. They are now self sufficient with the drugs production. Upskilling of health workers, increased contact with maternity services, quality of care is improving, like I showed you by the ANCQ slide, content qualified antenatal care, and the community system platforms forming a link between household and health facilities. Like you can see, there's female health and family welfare assistance in Bangladesh, ASHA in India, female community health volunteers in Nepal. All of them are increasing the demand side, detecting complications earlier, and referring them to hospital facilities. So is everything a rosy picture? No. We have areas for improvement. Data on human resource for health is scanty, not just in Nepal, but in all countries. But in Nepal, to be honest, we really don't know where the people are working. The government sector has not been able to increase the posts, as per our liking. We've been trying, the minister has been trying, but the finance ministry doesn't allow you so many times. Despite the health minister trying his best, things don't work out the way they want because they have priority for something else. So, and then distribution, I alluded to earlier, and skill mix continues to be a challenge. Regulation and monitoring of private sector hospitals. That's important to ensure unnecessary interventions are carried out and to ensure that the benefits reach the poor. Like I said, C-section rates are on the rising trend. Although we do need to ensure access to C-section for the poorest, and also necessary C-sections have to be done to treat complications, but unnecessary C-section is being done. That's one of the challenges. One of the incentive is financial, but also the medical legal environment in the countries. People's expectations have been pushed very high, so the demand is, very people demands C-section, and also if anything should go wrong, the tolerance is less. So vandalization of health facilities, traumatizing health workers, all of these things also happen. So unfortunately, that has also led to rising C-section rates. And quality of care and facility readiness still needs further improvement, and quality and content of postnatal care, especially antenatal care, is on the improving side. I showed in my slide, but has not reached 100% level. And postnatal care is the weakest component of our care right now, because most of the maternal deaths I didn't show in the slides, unfortunately, but if you look at the time of death, postnatal period is the most critical. Most deaths happen after the birth of the baby. So postnatal care is still a weaker component. So areas for improvement: further inequity, persistent barriers, women still report problems in accessing medical care through distance, waiting time, absent health worker, then other health system factors, including timely referrals, out-of-pocket expenditure despite free services is still very high, and a greater focus to stagnation in mortality figures in the last decade, especially around newborn health. I haven't gone into the details of newborn health in this presentation because I tried to focus more on maternal health. But if we are to achieve the sustainable development goals, we need to do better. And government of Nepal, after this study, actually around that time, has also come out with the roadmap for 2030. So we have committed to reaching our mortality to 70. At the moment, we are in 151, shown by the census in 2021. But the recent report, a projection of trends by the UN agencies, has shown us around 124, something like that. But I think this kind of progress, we will not be able to reach SDGs. So we have to do much, much better. I think that was the end of my slide. And like I said before, we had a team from London School of Hygiene and Tropical Medicine, including Loveday Penkakana, who did a lot of work here, and Dr. Lal from Nepal, and Dr. Paudel, and Dadia Adhikari with William Oswald, and Professor Una Campbell. She was the principal investigator from London School. I was the principal investigator in Nepal. So the exemplars collaboration, all the other colleges, other partners, and the country teams. And most of the presentation that I have here is published in the BMJ Global Health, Volume 9, Supplement 2, this 2024, last year. So with this, I thank you all and see the beautiful. This is the mountain I was referring to. The tallest 8 mountains in the world are all here in Nepal. This is the mid hill I was referring to. Looks so beautiful. But going from here to that point can take days. And then I have not even shown the Terai because the flat is, the plains are easier, and that's where the most population live. So for a diverse population in a diverse geographical area, doing what you can do to the best of your ability, try to improve the status of women. I think we've done a good job, but there's no room for complacency. And together, we must, continue to improve the situation. And I thank you all for your kind attention.
Thank you, Madam, for a comprehensive presentation. Now, I'd like to request participants to have your own comment, questions in chat box. If you want to put some queries verbally, please raise your hand. Then we will unmute you.
Doctor, during my earlier, I think people, when they registered, they had sent in some queries, which perhaps I did not address fully in the presentation because presentation was already made. One question was around community health. How do you engage community? I briefly mentioned that we have the FCHVs in Nepal and even Bangladesh, India, they have their own community health workers. So one of the things Nepal has done is we have something like 50,000 community health volunteers. These are women volunteers which form the link between the community and the home. So they visit the households, talk to pregnant women. They also form mothers group in the community. They hold mothers group meeting. They share nutrition information. They share how to prepare for birth. So the government has prepared a birth preparedness package, which outlines, what needs to be thought of. Like, for example, you should be ready with transport arrangements. You should be ready with things that you need for the baby. You should identify which health facility you are going to. So all of those elements of birth preparedness, those are communicated to the women. and it's ensured that they actually access care when they need. So that is how, and also these women promote family planning by distributing family planning commodities, by distributing oral rehydration solution for childhood diarrhea, and in some of the districts, they even manage childhood pneumonia through what is called an IMCI program, Integrated Management of Childhood Illnesses. And in some parts of the country, they even manage newborn pneumonia and newborn referrals by using the similar kind of training tools that they have received, like the IMCI. So that is how the community health volunteers are contributing to improve the situation of women in the communities, and working with other partners. I think now that we are in the federal system, the local governments have really improved their identification of pregnant women household. They even go for home visits after delivery of women, sometimes with chicken and other things to give to the pregnant women, and tell them about childhood vaccination and the need for follow-ups. But one of the things that has been written in the roadmap is the need for home skilled birth attendant visiting home to monitor women in the postpartum period, because that's the weakest link. As I said earlier, if you have a fever in the postpartum period, nobody, I mean, other people, untrained people cannot detect and treat sepsis and hemorrhages. Hemorrhage people might think is normal, but if you are anemic already, and if you lose even the normal amount of blood, that may be really jeopardizing your blood pressure, your general health. So I think all of these need further community intervention. But as for now, FCHVs, who are semi-trained, they are not trained health workers, they are volunteers, but have received certain components of training in terms of referrals and distribution of commodities and talking to women, preparing them for birth. I think those things we've done. So yeah, that was a question which some of the participants wanted to know.
Madam, there was one hand raised from Noble Father. Can we unmute?
Yeah, hello, good day.
Hello.
Yeah, thank you very much. It was a very insightful presentation. I'm Noble from Nigeria. We have the same challenge of very high maternal mortality rates, and I was very intrigued on how your country was able to reduce theirs drastically. I also work in the area of maternal and child health. My question is, how were you able to overcome the issue of the traditional beliefs, especially when you have the traditional birth attendants? How were you able to integrate them and make them to stay in the program? Because we tried that in Nigeria. After a while, they went back to doing what they are doing, and data shows that most of the maternal deaths arise from there when they are not able to handle complications that arise from birth. So how were you able to get them into the program and make them stay? And also for the others, how were you able to break the traditional myths and everything barrier for you to have this wonderful results? Thank you.
Thank you. Thank you so much, Doctor. Actually, Nepal, as I showed, we had a traditional birth attendants as well, which was around 4 decades ago, and we gradually phased them out. One of the things to do would be to teach them some of the basic elements, not train them formally, because you are wasting resources in training. You don't want to waste scarce resources, but let them be present during the birth so that they are counseling. They're staying at the top end of the head, towards the head end of the woman, and talking to her, giving her moral support, doing that kind of thing, where the technically trained people do the delivery and manage whatever they have to manage. So bring them together. If they qualify to be trained, like we phase them out, you making MCHWs, with 3 months training. So if they are younger, if they are capable, then you can give them some technical training and at least give them the kind of skill they would need. If they are older people, usually traditional birth attendants are older, you cannot train them, and you should not, because why would you waste resource in training things which is not really enough to save women's lives? So what we did in Nepal was gradually to adopt the ones which could to MCHW training. The ones which could not, they would be at the head end of the table, explaining to the women, holding a hand, doing whatever they have to do, supporting the newborn care when it's born, like oiling the baby and doing all sorts of things, but making them understand that birth now, it's a government's policy and you're not allowed. And if anything should go wrong, there would be legal consequences. So on one hand, you'd be a bit strict to them, but on the other, you'd be facilitative to them so that they come. And ultimately, it's about cash incentive, right? So if women are delivering in health institutions, then you don't need a TBA now. Previously, the births used to be at home, and where TBAs had a big role. But we have shifted the place of birth to institutions, and they have no role there except to refer women, to bring them to the health facilities. So by shifting the place of birth, by giving them the due place, and if they are capable, by giving them a few training. So in a phased approach, you cannot wipe them off all at once. Phase out, give them, make them MCHW, bring the women to hospitals, then they naturally phase out. That's the approach we have taken.
Oh, thank you, madam. Dr. Sanumaya
Was that enough? I perhaps didn't understand the second part of your question. Did I cover it all?
I was talking about overcoming traditional beliefs. As during your presentation, you mentioned the after, the postnatal taboo and beliefs. So how did you overcome those kind of orders? Because we have the same thing in Nigeria. Thank you.
Yeah, that part is a big challenge. Even we face. I was showing you my country geography. Like in the Tarai region, access is very easy. Health facilities are right there next to the woman's house, but people don't go. People just don't go. And some of them, they have, my mother-in-law didn't go. My mother-in-law doesn't allow me to go. My husband is out in the field working. I can't go. Women empowerment has not happened. As a result, the institutional birth rate, mortality rate are higher in 2 of our provinces, where, access-wise, it's fine, but behavior-wise, no. It takes time. It really takes time, and we are struggling with it. Now the government has put in infrastructure at places. Even the delivery has been made free, but inequity persists, and that's partly because of the factors that you mentioned. It's very hard to change the traditional thinking. I think we have to work together with the men and mothers and, continue to mobilize the community. And the locally elected, now with the federal system in our country, the locally elected governments are playing a part to promote institutional births, and many women have come in the leadership position. They are now the leaders and the mayors and the deputy mayors, and also leaders of the local, local, they call, local, like, well, whatever the name be. I just remember the name in Nepali, so I can't tell you in English language. But the most peripheral local level leadership, many women have come to that leadership position. So I think they also are trying their best. So I think it's all about women's empowerment. The health sector cannot do it alone, but you need to bring others on the fold. It's a difficult task. We are struggling with it too.
Yeah, Madam, you elaborated more on this topic. Now, Dr. Sanumaya Dali is asking a question. Dr. Sanu.
Can you hear me?
Yes, Doctor. Namaste, Doctor.
Namaste. Thank you very much. for the wonderful presentation. Learned a lot of things. And I remember when you went to receive the prize for our reducing the maternal mortality. Now, my concern is now from 2019, 2020, where we are. Now, where are we? Are we progressing the same way as we did before, or we are lagging behind? And as you correctly said, now we really need to focus most on the perinatal health because we are losing a lot of neonates. So I would like your views about it, Professor Sudha.
Thank you, Professor Bali. It is lovely to have you here in this presentation. Thank you. You've been a guide and a mentor to so many of us, including me. So thank you for joining. Actually, things have moved. You may know we used to have maternal mortality when I was your student at 539 per 100,000 live births, which came down to 229 in the last DHS in 2006. Then we had the census, which has shown 151. And the UN projection now is around 124. So from 124 to 70, it's an uphill task. And the last bit, when you go uphill, is the most challenging. We've done the easier bit, but the challenging bit remains. And one of the challenging bit is the thing that Dr. From Nigeria just talked about.
Yeah.
Changing behavior is the key factor here. We have the infrastructure, we have the human resource, but how do we make that change? How do we ensure effective utilization? And postnatal care, despite the infrastructure improvement, postnatal care is still a challenge. The government's roadmap, government has come up with a roadmap to SDG, which has highlighted this factor. And death from PPH is still common. So home visits by trained provider is one of the way forward. They have recommended in the roadmap, and I think we should all, as a society, Nepal Society of OB-GYN, we should push towards that issue. But progress is being made. I am sure we will achieve, maybe not 70, but we'll be near 70. Yes.
Thank you, Professor Sudha. Thank you, Chair, for giving me minutes.
Thank you. And Dr. Sudha, there is one query from Suman Gurung. Why neonatal mortality is still stagnant as per the NDHS data?
Newborn, and not just in Nepal, but globally, newborn is a difficult thing to handle. And more newborns are surviving now with early prematurity. You know what I mean? Extremely premature or very premature babies. And that is a lot of resource intensive factor. I showed you in my presentation that government had tried to make newborn care free, but then we stopped it. The reason being, it's unsustainable. Extremely premature babies, even if they survive, the long-term sequelae for them in terms of their mental development and others. And Nepal is still a developing country. We are not a developed country. So being realistic and pragmatic is another factor. But for those babies who could be survived with, the basics of infection prevention, thermal, and then feeding and all those kind of things, they are improving. Government has set up the milk bank now in the central hospital, and it's spreading to peripheral hospital as well. So mother's milk with all its immune enhancing properties is being available, and most of the hospitals are mother-baby friendly. So the bottle feeding and all those practices which are harmful to the baby are getting minimized. It is a challenge, but it's not really stagnant as such. Progress is made, but it's slow. We need to do much more. You are correct.
Madam, there's another query. How can Nepal strengthen its effort for improving PNC? That is the challenging thing.
That is $1 million question, and I have been talking about that a lot. So I think one of the things Nepal could do and has done, to be honest, Dr. Lal, which I mentioned, is the leader now in Family Welfare Division. And even before him, the current Secretary of Health, who used to be the leader of the department, Family Welfare Department. What they've done is the national roadmap, they have given it to the province to make provincial roadmap, and the provinces have worked with the local governments to make a local government roadmap. And for partners who are working in safe motherhood, my request would be to talk to the local government authorities and then make sure that they do what is written in the as per the roadmap. So one of the key factors is postnatal visits, ensuring that women are not discharged too early. Many of our birthing centers, as you may know, there's no provision to keep the women post-delivery because security, food, other things matter. So they're usually sent home early. And in the bigger hospital, because of the rush of the patients, they are sent home even before 24 hours, so, and women go home and die. So you need to be really careful about early discharge. You need to be really careful about retaining them, at least observation till at least 12 hours in a birthing center, and for the health workers to visit at home and ensure that things are smooth and okay at home. That's both for mothers and newborns, because newborns need all the thermal protection, feeding, and then our practices may prohibit the baby. In some of the communities, they don't feed, early, because colostrum is the best food for the baby, but some communities don't give that. So I think all of these challenges which are related to behavior, they need to be addressed. But those elements are all written in our roadmap, which needs to be reached right down to the grassroots.
Jaya is putting another query. Are there any PIH specific activities? Because this is the second leading cause of maternal mortality in Nepal.
For PIH specific activities, I think detection is most common. And as I had shown in my presentation, the content qualified antenatal score has improved, which means blood pressure is being measured more frequently compared to the past. So that is the basic ingredient that you need to have in an antenatal clinic to detect PIH, right? So after detection comes the management. So referral, if you cannot manage at the lower level facility, refer up. That's the second step. The third step is when you go to the higher level facility, if it's severe preeclampsia, all the protocols associated with that, and Magsulf now is universally available in the health system. So magnesium sulfate to prevent and treat eclampsia, antihypertensives, and availability of C-section for elective cesarean if need be. So I think those are the elements that are in our protocols. Those are the things that need to be followed. And I'm very happy to say that they are being followed to a great extent. But postpartum eclampsia is also common. So some of the women who have been discharged early may go home fit and die. So the government actually is doing what is called a verbal autopsy for home births as well as for institutional births. So in that, specific questions are asked, and you are right in saying that, yes, PIH is an important cause for death. Those, I think, really need to be looked at from all these levels, right from ANC to delivery to postnatal, because postpartum eclampsia is also common. So thank you for the question. It's very important issue.
Shreyasi's query is the role of technology and innovation to improve maternal health access and the quality in your experience.
Thank you. I've heard so many times to say that, maternal health is not a rocket science. And I believe that. if we did what is supposed to be done, even without using technology, we will be doing a great service to women. Our lacking is not by not having technology. Our lacking is by not doing what is already available to the satisfaction of the woman and the healthcare provider, and the right thing to do. So that is given. I would not like to jump to higher technology. Having said that, I would like to point out that technology is being used now in Nepal much, much, much more than before. For example, antenatal screening with ultrasound scan detects abnormalities, detects multiple pregnancy, detects placental location, whether you are going to have, placenta previa. So all of these things, use of technology. Yeah, it's being done. Cardiotocography, we never had. I learned with a Pinard stethoscope. Now, CTG is available in most health facilities. So fetal distress detected earlier. So that is available. In difficult cases, MRI and CTs, all available. Management of eclampsia, we never had simple drug like Maxolf in our system, now freely available. And now tranexamic acid and all these, the bundle approach for management of postpartum hemorrhage, that is routinely done, should be done, being trained. And one of the things which I need to highlight, even the partners have supported, is the WhatsApp and phone link and, telemedicine. In a difficult situation, the health worker can communicate with the doctors at the central level in larger hospitals and ask what needs to be done. My colleague Swaraj, who may not be in this presentation today, she has helped a lot of women through programs supported by One Heart Worldwide and the government of Nepal. And government of Nepal has even used helicopters to lift women from the mountains to the referral hospitals, so that given the weather not being a barrier, helicopters are sent to pick women. So all of these are use of technology, right from basic improvement from Pinard stethoscope to cardiotocography, to nothing to bring women to using helicopters for women and using the telemedicine technology. So all of that is being done, should be done. They are the best things to be done. We should adopt all the newer technologies, but non-availability of newer technology should not be a barrier to provide the care they should receive. So that is my message to all. Do what needs to be done up to the level that can be done without advanced technology. And that is not being done well, I must say. We have to prioritize that.
Next, Dr. Mahesh Maske from panel is going to put some queries or his comments.
Yeah, I first want to congratulate. Can you hear me?
Yes, I can, Dr. Sab.
Okay. Yeah, I want to congratulate for such an excellent presentation, and you also brought back some memories of those days when we were trying to, bring those policies to deal with the three delays, and universal coverage, free maternity care. So all this. And after 16 years, when we are looking at the data, what we are finding is that maybe the challenges has slightly, become different, and we have to think in an innovative way to uh, meet the target of SDG goal, because we have only 5 or 6 years left. And the rate that you have shown, the decrease of maternal mortality, is about 6.2%, you have written, right? And it needs to be around, at least around 15% to reach 70 per 100,000 live birth of the SDG goal. But what is interesting in Nepal's situation is that in this recent census, findings, about 50% of the municipalities, local level governments, have zero maternal mortality. Okay, So more than 50% have the highest maternal mortality than average 151. So the average 151 per 100,000 comes because of that averageness. And therefore, the challenge is to find out the high-risk groups, okay, high-risk areas. And then there's another interesting fact is, as you have also mentioned, that almost 90% of institutional deliveries are there. The skilled birth attendants have also increased quite a lot, but still the deaths are happening. So the people are going to institutions, hospitals, birthing centers, but deaths are happening. And postpartum period is where the most mortality happens, right? So therefore, the quality of care has become a big issue, which you have mentioned in your last slide, the two quality of cares, right? So if we could have that, and we could do that because our registration in the health post, our registration in the female community health volunteers, all these have very good data, which has not properly recorded and analyzed, and cross-checked. So if we could do that, we have a system of monitoring each and every pregnant mother. We know they are pregnant, and you can follow up for their delivery to create an environment where she could have a safe delivery. So if we could do this multi-pronged approach, probably we can increase the rate of decline of maternal mortality from 6.2%, double it, maybe 15%, and we can reach to 70 per thousand on an average per 100,000. So probably these are the things where now our policies needs to be focused on. And the beautiful thing is that over the years of the policies that we have taken, we do have those thing in place where we can gather the data and monitor every year, not only an average of DHS doing a survey of Nepal, but each and every ward level or municipality level data can be recorded. It's only the political will of the health ministries which they have to go for this one. This is my comment. Thank you very much.
Thank you, Dr. Maske. I agree with everything that you said. And the local governments do have a significant role to play. I think because of the COVID issue and because of the transition to local government, even the data analysis, which used to happen at the district level, was somehow not happening, because now the data goes to the not to the district, but to the local governments, not at the district level for analysis. So, and then the province is, district is not under the jurisdiction of the province. So the local levels are really independent by themselves. So I think one of the things forward would be to really capacitate the local governments to analyze and use data, but those systems exist. So it's only about giving them a proper orientation. And I think these steps have been mentioned in the roadmap. And that is why I was highlighting that roadmap at the local level is key. And you are very correct in saying that although the infrastructures are there, in some of the districts, the mortality is still very high. And that is to do with the factors that the Nigerian colleague just highlighted in the presentation. It's about changing behavior. So we need to have some behavioral interventions as well. Yeah.
Thank you, Madam. Almost we are towards the end. There is one last question that we have received so far is about 8 antenatal care visits. Is it scalable or practicable in a today's context? It is put by Mansingh Adi.
Thank you. Actually, I was also part of actually, I did lead the development of the roadmap for the Nepal government as a consultant in the last couple of years ago. And that was a big question we discussed. Where 4 antenatal visits were not happening properly, government had to give incentive to women to attend the 4 visits and make sure the health workers give whatever needed to be given per visit. How come having 8 visits is realistic? It's not, and we really argued about that. And the compromise was let's make 8 contacts, 4 visits. So minimum 4 visits is still there, but at least 8 contacts. So you can even contact the woman by phone and ask if she has any problems like, headache, blurring of vision, swelling, any signs, how's the baby doing, is baby moving well. So those are the contacts which may be virtual. So that was what was agreed. And 8 visits is difficult. Having said that, those of us who worked in the hospitals, we were following our traditional teaching and not following the government regulation of 4 visits. We were following up to 28 weeks, 1 month. After that, 2 weekly. After that, weekly. So that's what were being done at the central level hospitals and big hospitals. And that is where the bulk of the patients come. So in an urban setting, I think that's feasible because that was being done and continues to be done. In a rural setting where things are difficult, minimum 4 visits, at least 8 contacts through either phone or whatever. And phone is now available with everyone.
Thank you. Thank you, madam. For all participants, the link has been provided in the chat box for the feedback survey. So you can fill it up. And if you have any queries, you can keep it posting your questions. We'll be addressing it later. Thank you, madam, for your comprehensive presentation.
Thank you, Dr. Baral, for leading this successfully, and I'm so happy to be with you all. Thank you. Excellent.
Thank you, all participants.
Thank you, Louis, and the team from Oxford Policy as well.
And I'd like to thank to all participants for active participations. And madam, you have made this webinar of success, and you rightly highlighted the value of money, programs, and readiness to work. And you were the leader in the country to start the intervention to reduce maternal and maternal mortality as well. And now towards the end, our panelists will address your questions later, and the recordings will be provided in the link, and you will be looking it later. And if you have any queries, you will be addressed accordingly. Thank you very much for your active participation and interactive sessions. For all panelists, our support teams, our organizer, Nepal Public Health Foundation, and Global Health Network, Oxford University. And last but not the least, Dr. Mahesh Maske, who is the Chief of Nepal Public Health Foundation, and Mr. Louis, who is supporting us to successfully conduct this session. Thank you very much. And I was very much delighted to chair this session this time. And we'll be working together for the further webinars later on for our sharing the experiences and learning some skills, knowledge, and information from all over the country. Thank you very much.
Thank you.